right? So this is the issue that can happen with AVMs, okay? So if you have arteries and you have veins, so arteries have pressure going in, and so veins draining out, and then you have a malformation, which would be AVM. That's how you get the name.
Mm-hmm.
There's a couple of issues. In the normal situation, the artery is high pressure, brings blood from the heart to your tissues, okay? Then it comes back through the veins. And just like plumbing of a house, you have water going in, that's high pressure.
Mm-hmm.
Goes through the faucet, you have the basin, which is the tissue, but fluid flows from high pressure to low pressure, otherwise it doesn't move anywhere, or it goes backwards. So it's always going high pressure, less. If you notice, all the drains in the house connect and go back to one place,
Mm-hmm.
right? In the heart, it's the same thing, right? So you have one side that shoots it out,
Yeah.
but everything has to come back to the heart.
Right.
So everything starts coalescing again, after that. So it's the tissues that actually slow that pressure down, which actually lets the blood exchange their stuff, and then it goes. Okay, that's just the physics of it. Okay, the malformation does not allow that to happen. It basically goes woo, and then drains right back out. Okay, so that high pressure stays high pressure.
Mm-hmm.
Part of the problem of that is that this flow in the draining vein is elevated, right? It's higher pressure.
Right.
Drains are not meant to hold that kind of pressure. It's like putting a fire hose to the drain directly without going through the basin.
Mm-hmm.
Okay. It can then potentially back up the drainage system, right? They're all connected by
Right.
pressure, and then it could back up in the bathroom sink, right? Or the toilet or something like that, right?
Mm-hmm.
So that's the potential issue. There's about a 4% chance per year that you could potentially have a brain bleed from that. Okay.
Okay.
Yes.
Does the 4% chance each year add up or remain 4%?
It's 4% per year. So
Plus.
the only time you add it up is if you say, what's the likelihood of this happening in my lifetime? Okay. The good news from Dr. Spalding is that the cancer diagnosis you have is cure.
Mm-hmm.
Okay. It's beautiful, right?
Yep.
If you were someone, heaven forbid, and I'm not saying you are, that says if you only had 6 months, 12 months, or something like that expected to live, you know what I would tell you? There's the door.
Yeah.
Okay.
Mm-hmm.
The question is always, what is it in my lifetime is the risk of me having a problem? Is it something that's worth it to me to fix before there's a problem or not? Especially when it's the brain. If a problem occurs, we can't always go back and fix that.
Right.
Once a problem happens, the brain is gone. Okay? We can't put it back together.
Right.
Okay? At least with the current technology. Okay? So the question then is, well, what do we do? If we expect that nowadays people live into their 70s and 90s, especially if you have a good cure, right? We have 30 years, 4% per year. In that time span, you have about 120% chance that something could happen.
Mm-hmm.
We just don't know if it's going to happen in year 1,
Or
month
year
6,
20.
or year 30, or
Mhm.
25, or 29. And ideally, what if it happened at year 29 in 11 months? Once again, if I could tell the future, I would tell you, there's the door. But beyond that, it's not a gamble, but it's kind of a game of chance.
Mm-hmm.
Okay, I think gamble is too strong of a word, but the question is how you like to handle your health diagnoses and things like that. Okay, so if we go to here, I want you to see how we see this. So the next thing is seeing what you have, and what you have is showing up right here. You actually see a tangle of vessels here, and you can actually see it right here. It's in the left frontal region, so it's like right around, if you go a little bit further in here.
Okay.
Okay, straight in here. Okay, and it's, what did they fix in your left eye, by the way?
We teared up.
Just a tear duct?
Mm-hmm.
Okay. So it's basically back behind your left eye. This is your left eye.
Mm-hmm.
Okay. And then there's this here. So it's this doodad right there.
Yeah, they thin the optical nerve. That's why I have to wear glasses.
Okay. Do you have trouble seeing out of that eye already?
I can see the big letters.
Okay. Okay. But regardless, this is what we deal with. Okay? And that's what we see, and that's what we would do. In the workup of this, to figure out what we do for it, it depends on where it is, where are important functions, and weighing out where the blood vessels are coming from, right? So there's lots of things, right? This is blood vessel related, so we need to know where the blood vessels are coming from exactly, what's feeding it, things like that. There's a test that figures that out. It's called a cerebral angiogram. It's much like a heart cath, but it's for the brain, okay? So there's that. The second thing is, what functions are around it? If it's around some critical functions like your ability to speak and create language for you to understand and things like that, we need to know that. If it's too risky to get to, or glue, or things like that, then that affects what we would recommend on how to treat it. And we'll talk about that in a moment. So that's another test. That's called a functional MRI, okay? So the final thing is, well, what do we do about it, okay? Depending on what's around it, what we do could effectively change, right? We can always say, you know what, I get you, doc, I understand, gotta go with something, I'm happy to take my 4% per year. And that's okay. There's no right or wrong answer to this, okay? So there's that. The second thing is, well, we explore this, get the test to figure out what's best, and that would be cerebral angiogram, fMRI, which is a test in which you're in an MRI scanner, and they actually ask you questions, you read, and you do all this, and then various parts of your brain line up where it needs to be, okay? And then that tells me, oh, it's right in the middle of that stuff. So then I would know that, well, then I don't recommend some of these other options. Hold on one moment. The next way that we would deal with this is potentially glue it. As you imagine, this is just an unusual flow pattern, okay? This flow pattern can be blocked off, and if we can block it off with glue, then no more flow goes to it, so therefore it can't grow or get bigger. Which leads me to another point. Well, if we do nothing about it, these tend to get bigger. In life, people and things usually always go the path of least resistance. So if you have a choice and you're a blood vessel, would you rather go through the normal vessel to feed all the brain stuff? Or would you rather go to this slide that just takes you and you're back to the heart, right? So eventually more and more go through this, and this just gets bigger from just the physics of it, right? Just more, things just tend to go that way, okay? Now, we don't know how fast it will grow. It's different for everybody, but it's positive that this is fairly small, okay? So the last thing we can do for it is the traditional way, where we open your head, go down on the brain, and actually get around it and pull it out, okay? So that's the craniotomy for resection. Depending on what we see, where things are, that all affects things, right? Pros and cons to each, all right? There's another thing we can do, and you've already gone through this, but radiation therapy. We can zap it with a high dose radiation and it shrinks and goes away, okay? That usually takes 2 to 3 years for it to sclerose. As you know, radiation is not a death ray. It doesn't, you zap it, you have to give it time. And then it does its thing. It takes about 2 to 3 years. So for certain people, they say, oh, I definitely just want radiation. I'm not letting you go into my head, and I don't want this or that. The gluing is something that actually potentially can help, even if we combine it with other things. If you make it smaller, then you can more effectively either radiate or resect it safer and things like that. But at a minimum, for diagnostic testing, I would say either AVM or angiogram and fMRI to know what we're dealing with, and then from there we can talk about what to do.
And that was my question. Depending on what you guys end up doing, if anything at all, it would have to be definitely after those tests as far as what to decide on how to attack.
If I were to give you my opinion, I would like to know those things. And hopefully it makes sense, logical sense, right?
Yeah.
I mean, I need to know how important those tissues are, what's in the way, like where all the important china is in the room, before we can say, well, this is how we're going to move it out.
What motor functions will be
Right?
operated.
If you have the most expensive vases right next to it,
Yes.
well, then you're going to want to, if we decide to treat it, one, it's like, is it even worth it at all?
Right.
Or two, well, maybe we use the death ray that just lobs something over there and then get it.
Right.
Or do we actually send in the troops to move this stuff around and then take it out?
Mm-hmm.
Right? That's the best analogy that I have.
What happens in the frontal lobe?
The frontal lobe controls a lot of what we call executive function. Okay, now you're right-handed, so also potential speech, understanding, and things like that. So those are the things that I would watch out for, and that's why I think that the fMRI is going to be so important as well.
Okay.
That tells you, is it right next to it, and things like that. This is in, you know, is it going to be surgically accessible from an open stance? Maybe. But we will see. Okay, you only have certain corridors in. Is it something where if I try to glue it, if some important vessels are right next to it, am I going to take the shot? Probably not, which would point to, if we treat it, we'd go radiation. So there's a lot of what ifs right now, and I don't like to play what if games because it doesn't matter, right? It's you. So we got to figure out what's best for you. So, I mean, ultimately, for me, I think the plan forward is still finding out more. We have the time to do that, and there's no reason to rush things.
If his cancer should return, God forbid, and they put him through more treatments, will that affect his vessel?
In theory, you wouldn't think so. This is something that you were probably born with to begin with.
Mm-hmm.
Okay, so it's probably been there for your whole life. It might not have been this size, but it was probably there since you've been born.
Mm-hmm. And it's not the hood's fault because I hit me here.
Yeah, he had 3,000 pound
No, a 700-pound
grinder hood that hangs up above the
Oh yeah, that's Trump.
BAM, and
Yeah, that probably wouldn't do anything.
he never did anything about it. Just got his head sewed up. Okay. Lots to know. So when do you believe would be a good time frame to visit that test to set it up?
So the fMRI will happen when it gets scheduled. The angiogram can happen as early as in a couple of weeks to whenever you feel like you'd like to get it worked up further.
Okay.
I think that even if you said you waited 3 months, for example, at 4% per year, that's probably equivalent to 1% in 3 months, right?
Right.
So it's kind of...
So next year wouldn't be out of the question as far.
It's not out of the question.
Yeah.
It just depends on when and how you want to plan things.
Sure.
Yeah, well,
We
I'm
wouldn't
just,
know until we get it. So
Yeah,
just so you know.
I mean, I got vacation time right now. Next year I won't have
Yeah.
because I didn't work most of this year.
If he
Okay.
were to have a procedure to fix it, remove it, glue it, whatever, what is the time frame he would be looking at for being off
A
work?
lot of that depends on... So a lot of that actually depends on... hold on 1 second. You know, since you quit smoking, I'll cut out tobacco abuse. I'll resolve that to make it, but I can put history of tobacco abuse. That's actually good. Congratulations.
It's rough sometimes, especially at work now.
Mm-hmm,
When I was sitting on my butt at home, it was easy, but
Okay, let me just add that. Okay, so what I'd say is, you asked me, we're talking about like, what you would be considering, like as far as timing.
Excuse me.
I think that in the long run, I don't think that there's a magic answer to what's the best thing, right? It's all dependent on how you process and handle the risks. If it's something that you're like, I'm fine with the 1%, and I would be too. It's like, it's only 4% per year. So if you're dealing with it from short periods to short periods, I think that's fine. But
and currently, right now, I'm getting a scan every 3 months. So.
Yeah.
And as far as time frame as treatment, okay, I would say that as far as the staged portion of it is, we need to get those tests, and then I'd say we get those tests to figure it out. But in order to figure it out, if we embolize it, sometimes it takes multiple embolizations, so it's possible it might take a stage or two. So, and we separate that by a week or two. Then we say, well, if we're going to do craniotomy, we tack it on a week after that. If you attack a little bit of this at once, let's say we get rid of a third of it, and we usually aim to get rid of a third to half at a time, unless we're able to take it all out. You can imagine that if this is all the flow that goes through it with all the pipes, if I get rid of, say, 99% of it, the flow to this area is still going to be the same, but all of a sudden it's only going to go through 1% of the piping.
Right.
That greatly increases the risk of bleeding.
Yes.
Right?
Yeah.
Your brain hasn't gotten a chance to get used to that pressure change.
Right.
So the issue is that's why we target multiple embolizations usually. Okay, so that would be a couple of weeks. And then if we did a craniotomy, that'd be another week. Okay. Now, if we just decided to radiate it, we could potentially get all the imaging that we need to target it and treat it, but that is done in one day. High dose, zap, done.
And then keep an eye on it for a couple of months.
Well, years actually, and then we check it again. Okay. So in this area, I'll be honest, I'd say it's a 50-50 of if I recommend embolization with radiation or embolization with resection. If it's embolization with resection, then that's a little bit longer than obviously if we decide radiation, right?
Right.
Radiation is just quicker, easier. The recovery's nothing, basically, right?
Right.
We also might find that it's not an embolization candidate, and the only thing we can do is radiation. Then it's a day, right? 2 days. You have to see him get the mask made, and then the thing, right?
Right.
So
I already have my mask.
well, it'll be different.
Yeah.
It'll change. We like to be accurate.
Yeah. It won't be here anymore. It'll be here. Yeah.
We'll be accurate. I guess we'll be accurate.
Please do. We got to get running, don't we, Beck?
Yeah, we do.
But essentially, that's about it. Okay, so those are the things to consider. What we can do is you can think on it and things like that, but at a minimum, I think doing the angiogram and the fMRI are important, and then we can regroup and figure things out beyond that. But those are the main important things that we need to talk about.
What would be a direct number that we would use to schedule that?
So the direct number would be printed out here.
Thank you.
It'll as we go over there, but basically consider angiography. So consider and schedule angiography and fMRI.
What does the F stand for?
Functional.
Thank you.
Determine. All right, it's fMRI, but functional MRI to determine best treatment plan. That's when I can figure it out. And then in general, it's watch it. And if you do 4% annual risk of bleed or change, etc., watch it, treat it. Treat it is glue or any combination, glue, surgery, resection, or radiation. Okay? And that's basically the main points of it here. This is just meant for you to remember what we talked about.
Would it be just one zap or more than one zap?
Radiation is typically one zap.
Yeah, that's what Doc Spalding said. Normally, he says if it's small enough and looks good enough, we'll go in, zap it one time, and
I have a feeling that might be the best thing for you based on, it's just a feeling. But that might be, and we'll get there. But
We'll find out
as I
after
said,
the
we have to get
test.
the other test to
Yeah.
confirm.
get the other test and confirm it, and then go from there.
As you know, we don't guess.
Yeah.
Okay.
That would not be a wise thing to do when it involves the brains.
Yeah, we don't like guessing.
Yeah.
She keeps saying she wants to donate my brain to science. I keep telling her I'm using it right now.
For now.
Very good.
Questions at all?
You very
Pretty
thorough.
much answered them.
Yeah,
So.
very thorough.
Well, believe it or not, obviously this isn't the first time we've had to do this. So that's why sometimes I'm sorry to cut you off for some of it.